morning, everyone, and welcome to this special live episode of our PRS Journal Club podcast, live at Plastic Surgery, The Meeting 2023. My name is Rami Kantar. I'm one of the PRS resident ambassadors. I'm a fifth-year plastic surgery resident at NYU, and I'm joined by my co-resident ambassadors, Ronnie Shammas from Duke University and Yoshi Toyoda from the University of Pennsylvania. So today we have the very exciting opportunity to welcome Dr. Karp to be our guest speaker for this podcast. Dr. Karp is a professor of plastic and reconstructive surgery at NYU. Dr. Karp is also a director for the American Board of Plastic Surgery, which is not surprising given that he is a master educator, a master surgeon, has dedicated his career, or a big part of his career, to training residents, and we're very lucky to be trained by him at NYU. He's also the vice chair of the Department of Plastic Surgery at NYU and the chief of plastic surgery at NYU's Tisch Hospital. He's a prolific researcher, has published more than 150 articles, more than 15 book chapters. His expertise includes or encompasses the breadth of breast surgery, breast reconstruction, body contouring, and we're very lucky to have him train us at NYU. So today we'll be presenting the article, or we'll be discussing the article called Analysis of Incidentally Found Proliferative Lesions in Oncoplastic and Macromastia Breast Reductions by no other than Dr. Karp himself. As a quick reminder, this article, along with all of the other articles for our previous podcasts and our previous podcast episodes, can be found on the PRS Journal Club or PRS website and can be downloaded all for free. So to begin by introducing the article, we all know that breast reduction is one of the most commonly performed and popular procedures in plastic surgery. The indications for the procedure includes either macromastia, oncoplastic reduction, or symmetrizing reductions. One of the things that has been discussed a lot in the literature is that the incidence of proliferative lesions in specimens following breast reduction can be as high as 15%, and has been reported to be even higher in certain instances. So what is special about this study that we're discussing is that it is the first study that actually compares the incidence and the risk factors for proliferative lesions and carcinoma that are found in breast reduction specimens from patients undergoing either breast reduction for macromastia, symmetrizing reduction, or oncoplastic reductions.
All right, so to go over methods, data was collected from 3 patient groups between 2017 and 2019. Those who underwent a breast reduction for macromastia, patients who underwent symmetrizing reduction or oncoplastic reduction were included. Patient characteristics were collected, and univariate as well as adjusted multivariate comparisons were performed between the 3 groups. Fibroproliferative lesions or carcinoma were defined as LCIS, lobular carcinoma, DCIS, ductal carcinoma, atypical lobular or ductal hyperplasia.
And then reviewing the results. So a total of 632 breasts were analyzed, 502 reduction mammoplasties, 85 symmetrizing reduction procedures, and then 45 oncoplastic reductions. Patients who underwent reduction mammoplasty were significantly younger than the other 2 groups, as expected. And then the highest rate of atypical proliferative lesions or breast cancer were found in symmetrizing reduction specimens. This was 17.6%, followed by oncoplastic reduction, 13.3%, and then reduction mammoplasty, which was 3.6%. Older patients and those with a personal or first-degree family history of breast cancer were more likely to have these lesions. And then on multivariate adjustment, older age was the only significant predictor for these lesions.
So overall, I think what is very unique about this study and why we picked this study to be discussed today is that it is the first study that did a direct comparison of the incidence of these lesions and also analyzed the risk factors that are associated with the development of these lesions across 3 groups: patients undergoing breast reductions for macromastia, symmetrizing reductions, and oncoplastic reductions. And I really think it highlights the need for plastic surgeons to be vigilant when treating these patients and closely collaborating with the breast surgeon in order to make sure that these lesions are not missed. So I think to start off the discussion, Dr. Karp, we'd love to hear what triggered the study and what your thoughts are about the study and whether there were any findings that were surprising to you.
Well, I mean, what triggered the study, actually, to be honest with you, is a typical, like, a resident rotating with us who was actually interested in doing the study. I mean, it's, and that's kind of an interesting thing because, the residents rotate with you, and a lot of times, they want to do a study, and I have to give Dr. Kerry Marson, like, a lot of credit. She rotated with us and brought up this idea and discussed this with us, and she really took this and ran with it, because there's a paper this in October, but there's also another paper related to this, a different topic coming out in November's issue, and kind of really looked at like our breast reductions and tremendous amount of work. Got another resident medical student maybe involved, and really looked at this, and so I give her like tremendous amount of credit for doing this, because a lot of times like the residents are with us and they propose a project, and then like the minute they rotate off the service, like it's like it's like radio silence. So she like ran with this, like all of a sudden she had like all this data, and it is interesting because you look at this, a common procedure that we do a lot and we've been doing for a long time, and could you actually learn something, and the thing is that like I learned a lot from this study. Like this study will actually change, to some degree how I practice, and it's not going to change the regular breast reductions because the 3-point-some-odd% incidence of proliferative lesions, most of them are like ADH or ALH, which are really more like precursors, and will trigger us to send the patient maybe to a breast surgeon or a breast oncologist, and they'll be monitored much more closely, and they'll in some cases even be put on tamoxifen or other or other methods. There is like a system to follow these patients, and that's about it. If they haven't had a breast MRI, they'll usually the first step would be get a breast MRI and then get followed more closely. But curiously, the oncoplastic patients, and even more interesting to me, are the symmetrizing patients. The oncoplastic patients are all patients with breast cancer. They've all had MRIs. They've all been followed. So it goes to show you that even though these patients have been looked at very carefully, you're still finding like 13% incidence of proliferative lesions that you did not expect. So I think one thing I've learned from this, and haven't really done it but probably should do it, is usually that breast reduction, contralateral breast reduction, it comes out as a big specimen, and there's no reason that I can't put like a markings like we would do for a mastectomy, like a marking suture at 12 o'clock, superior stitch and a lateral stitch, just orient the patient to the specimen so that if we do find something, at least we kind of know where it is in the breast and not totally blind. So I think that's one thing I learned from this study. And I'm not going to mark every little nook or cranny or little bit, but we do take a big specimen. The majority of this comes out as a big specimen, sometimes the only specimen, and I do think it's worth marking it. So I think that's one thing. And the second thing, the symmetrizing cases are a little different because they're done distant to the cancer. Like it could be, a lumpectomy patient comes in years later, saying that, the unaffected breast is bigger and wants a lift and a reduction, or it could be, a breast implant patient where you're doing the tissue expander change and now you're doing something on the other side, or it could be a deep patient, unilateral deep, where you're doing something, though I do try to do the reduction at the same time as the deep for unilateral, but even in that case I would mark the specimen. And those patients, the ones that are distant, with 17% incidence of finding something. So, I think it's critical that those patients get worked up and make sure that they are up to date on their mammograms. Probably a lot of them would maybe benefit from an MRI before doing this surgery, just to make sure you're not, you don't miss anything. So, it's hard to believe, but for doing this for 30 years, I did actually learn something from this study.
Amazing. Thank you for all those great comments, Dr. Karp. And we have a question to piggyback off of that, but to the audience, everyone's welcome to ask any questions, and the microphone is right over there. And as a reminder, this article, this podcast, along with all of the previous articles that are discussed in PRS Journal Club and the podcasts are available for free on the website. So make sure to check them out.
My question is if your article is only related to oncologic-related cases or general breast reductions, and if you think that this discrepancy is human-related or equipment-related. Because, of course, in this country, also in Brazil, we use the state-of-the-art technology to do mammograms and MRIs and ultrasounds before the surgery. It's a routine for every surgeon to have these exams early. And you mentioned that your paper found 13% of incidentally found lesions. And extending my question is that if you also have the same experience on regular reduction mastectomy, not related to other side cancer, and if you think it's just a human error, or could be the equipment that's not sensitive enough to find the type of lesions that you saw?
No, most of the lesions are ADH, atypical ductal hyperplasia, or ALH, atypical lobular hyperplasia. These are things that are not going to show up on imaging. I just think that what happens is you have your kind of regular breast reduction patients, and again, the younger patients, I just treat them like any other patient, and the ones that meet the criteria for having a mammogram, should have a mammogram. So it's just the patients that have had cancer are at increased risk to get another cancer. And, and I think this is just the idea to be aware of that. And again, most of the lesions are still ADH or ALH, but there were some incidents of LCIS, which is also not cancer, or DCIS. And I think that you want to make sure, like if you find these lesions, that these patients end up in a real, properly organized surveillance program.
I need here it is. I wanted to ask a question about preoperative imaging and non-oncologic breast reductions. I know conventionally breast radiologists prefer to have a radiological baseline of the breast, and there are different ways that different plastic surgeons have decided on preoperative imaging, whether to follow just the regular guidelines from the Breast Cancer Society or just not do breast imaging pre-op for patients that are under 40, for example. What are your thoughts, and what's the algorithm you follow?
So, if they don't have any history of breast cancer, they're not a BRCA patient, then, I use 40. Once they're 40, I do want them to have, standard mammogram. Less than 40, then, this is where it becomes like kind of everybody's own opinion. So I think if they're a BRCA patient, I would probably image them at 30 to 40. And even, if they really have a BRCA and a strong family history, I might even consider even at 25 to get imaging. If they have a family history, but it's like they're not like a gene patient, then I would image them at 35. But, I don't hesitate to get imaging. It's like pretty easy. And the question in terms of baseline, like once you've done the surgery, the breast architecture is completely different. So the next mammogram after this will be a new baseline. And you have to wait like absolutely a minimum of 6 months to a year really before doing that next mammogram, because it's pretty, they have to heal, and it's uncomfortable to consider, probably closer to a year for the next mammogram.
Got it. Thank you.
Hello, Dr. Karp.
Hey, Ali, how are you?
Good to see you. Thanks for organizing this, and I thought the paper
Rami
was
and these
super.
guys organized,
yes,
right?
yes.
Yoshi and Ronnie.
Yes, the dream team. Thanks for organizing this. I thought the paper was great. Question is, one, do you counsel your patients differently now, knowing this higher incidence, whether they're having, a reduction in the setting of a benign, macromastia or others? And then have you had incidences where you have found something on a benign reduction and then have had to go back, and do you go back with a breast surgeon to make sure the nipple's still fine and they don't injure the pedicle, or do you just kind of send them to the breast surgeon after that?
Everyone is different, and it kind of depends on what the pathology shows. So if we do a breast reduction, they find an incidental cancer and the margins are like widely free, then the only thing you haven't done is you haven't done any axillary staging, right? So you've kind of missed out on that opportunity. So you can't really do that. On the other hand, if you find something and they can't figure out the margins, and it's a little bit tricky. Kind of depends what you found. If you find LCIS, ADH, or atypical ALH, there's not much really to do. Like typically what they'll do is get a baseline MRI, and then they'll potentially put them on like some sort of hormonal suppression. I mean, if you find, DCIS, you can't be sure of the margins, then you might have to consider doing a mastectomy. So this is on a normal breast reduction patient where you're not going to sit there and mark all the margins.
And I like what you said about marking the specimen, because I know in a normal breast reduction, most surgeons don't necessarily.
No, I wouldn't mark it on normal breast reduction.
You wouldn't, given the findings of the
study?
study?
No, I wouldn't mark it on normal breast reduction, because we really very rarely, if you look at those patients, very few of them are DCIS or cancer. And the thing is, a lot of times it comes out in kind of like pieces. So there's usually a big piece, so you can consider marking that, because there's usually one dominant piece, but I haven't been doing that. But I think on the oncoplastic or the symmetrizing, I think it's probably worth doing it.
That was great. Thanks, Steve.
I actually have a question.
Please.
Yeah. In the paper, you discuss how the pathologists go through the breast specimens. I think you discussed, they just take 5 sections and that's it. For the symmetrizing and oncoplastic reductions, are you working with the pathologist to either take more slices to find additional lesions, or do you worry about finding incidental lesions like we talked about, like the ALH and things like that, that may not have much clinical significance, and so how do you weigh those?
Interestingly enough, we haven't, other than letting the pathologist know that the patient has a history of breast cancer, I haven't gone through and said, should you do more sections and things like that, or, I haven't done that. I kind of leave it up to their clinical judgment to do that. So we haven't really done that. I think that, it may be worth doing that, especially if there's a reason to think that they're going to have a very high incidence of having something, but we haven't really done that.
Yeah, thank you again for a great discussion. So for even the benign macromastia cases, do you always send, or those not covered by insurance too, do you always send the specimen for pathology, and is there an extra cost associated with it?
Okay, so that's a really good question, and it comes up on the cosmetic patients. So, breast reduction is like, a lot of the patients can be covered by insurance, but some aren't, right? Some are just not big enough. They don't have the insurance, or most people actually have insurance, so that's not an issue. But some people, the reduction is just not big enough to be covered. So I send every specimen to pathology. And, and every once in a while we get into this thing, like I don't want to, most people have insurance. Our pathology at NYU literally takes every insurance known to mankind. So as long as they have some insurance, it's going to get covered. We just submit it like a specimen, breast reduction, and, give them make sure they have their insurance information. It's in, usually in our system, we have Epic. It's like usually just there. It's pretty easy. In the occasional case, like maybe like a foreign patient or somebody who just doesn't have health insurance, which is actually remarkably rare, then, we kind of try to work something out with pathology so they don't get a bill, for some ridiculous amount of money that's more money than the whole surgery costs from the pathologist. So we try to work something out and just let them know this is a self-pay patient, and we try to work it out. But I will not ever do the surgery and not send the specimen to pathology, because I think that is, not standard of care. And it's, the same, unrelated to this, but the same thing goes for, like, let's say somebody in the office is coming in and they're an implant case, and I'm going to do a implant removal and like capsulectomy or total capsulectomy. I will send the pathology. I don't care about the implant, really. I don't have the pathologists tell me that it's a ruptured implant, but I will send the capsule. I'm not going to get anything out of the implant, but I will send the capsule, and it's kind of the same discussion, because I do think when you take things out of the breast, it should go to pathology.
Thank you very much for that great discussion. To the audience, again, the mic is open. If anyone has any questions, feel free to ask Dr. Karp. Dr. Karp, I have a question for you with regards to gynecomastia surgery.
Sure.
And what are some of the things that you can take away from this paper and apply in the setting of gynecomastia?
Not that much, I don't think. I do have to tell you that in the gynecomastia, there is an instance, obviously, of male breast cancer, right? But, I don't send, if I remove, like if it's an excisional gynecomastia where I go in, make an incision, take out the breast like a mastectomy, I will send it to pathology. But a lot of the gynecomastia cases are like combination of liposuction and this kind of pull-through technique where you just end up with, obviously you're not sending a lipoaspirate, but you end up like a lot of little bits and pieces. I generally don't send that. The risk of breast cancer in the male is low. Now again, if they're BRCA positive or if they have some sort of high history, of breast cancer and they fall into a group that, might have breast cancer. Another weird, odd group specific to New York is World Trade Center survivors. Like at this point, I think I've seen about 4 breast cancers in men who were, around the World Trade Center, like worked there or were, firemen. And so if they were like a World Trade Center, related to the World Trade Center, 9/11, then, I might consider sending that to pathology, but generally it's kind of not the same.
Great. Thank you all for a great discussion. Again, remember to download all the podcast episodes, all of the articles. Everything is free and freely available on the PRS Journal website. Dr. Karp, thank you so much for joining us today. It was a great discussion.
Right. Thanks, Rami, Yoshi, and Ronnie. Thank you all for doing this and putting this together, and appreciate the opportunity to be here.
Thank you so much, Dr. Karp.